So I'm going to present you 3 different clinical cases, but before, I would like to set some background. Follow the clinical guidelines of the ESE that were published in 2019, because as Dr. Banerjee said, it's very difficult to differentiate between reversible and irreversible pulpitis. There's the article of Waters in 2008 who states that he make a new classification of 4 different types of pulpitis. That's very difficult also, but we have to relieve in something. No? So I think that this is very clear. You have a bite-wing radiograph, and if you have a superficial or shallow lesion, okay, you can go for non-selective removal. You can go until hard dentil. You can hear the dentinal, I don't know the name, shout, no? I don't know the name in English, but you can go to hard dentin. The problem is that kind of lesions, no? They are more deeper, and the clinical symptoms, it depends on the patient. If they are very young patients, you cannot trust them sometimes. No? If they have MIH, molar incisor hypomolarization, they are a patient that has a lot of sensitivity. They are anxious to going to the dentist. They have fear of the dentist. So they will tell you that they have a lot of pain, and probably they have a reversible pulpitis. In that case, when the lesion does not enter into the pulp, into the chamber, into the first third of the pulp, and you can see a sound band of dentin, you can go for a selective removal, as you will see in the different clinical cases. And last, if you have a very extreme deep lesion, where you know already, you have to plan your treatment. Say, okay, I will enter inside the pulp tissue, so you will do the removal of the caries in a different way, and you can do a direct pulp capping or a pulpotomy. Regarding cleaning of the cavity, as Dr. Banerjee tells, it's very important to start by the surroundings in the peripheral area, because you want sound enamel and hard dentin in the periphery, and you want this kind of selective removal, just over the pulp chamber. And it's very important to use a bioceramic or a calcium silicate cement that is easy to place inside the cavity. Look at this one that you see in the left side. It's very sticky. So you place it and it comes out. It's very annoying placing it, while Biodentine, it's very easy to place inside the cavity. This is the new Biodentine XP. You have to be gentle, but it's very easy to place. It doesn't stick to the tip. And with a microbrush or a sterile paper point or with an endo plugger, you can modulate. You have to wait until Biodentine sets. The manufacturer says it's 12 minutes, sometimes it's 15 minutes. And for a children, when you have a children sitting in the chair, it's a lot of time. But you have to wait, and you will see the different color change until the setting is complete. This is very important, because if you want to do, you have to do it, but if you want to do a resin restoration over it, when you place the orthophosphoric acid, if the Biodentine is not set, all the Biodentine will become blue, the superficial layer. So you will have to wait to take it out and to start again. Here you can see the restoration. And finally, you have to check with an X-ray. So this is the first clinical case. And he's Pablo, 16 years old. He was referred to do the root canal of tooth 47 because he was in a lot of pain. He's not so young, but he's an adolescent, so sometimes adolescents are a little bit, I don't know. And you see that the lesion does not affect the pulp chamber, so we go our treatment plan for the selective removal. We did the caries removal, and look, the borders of the cavity are perfectly clean, and on the floor we leave this dentin. disinfection is optional. It's not optional, it's mandatory for direct pulp capping or pulpotomy, but for indirect, it's optional. You can do it or not with sodium hypochlorite or chlorhexidine. I like to do it because it's the same pattern in both cases. If you disinfect, you should rinse with saline after that. And the application of biodentine in a bulk fill. You can leave the last 2 millimeters of space for your resin restoration. And in my case, it's very important that the biodentine is only in the middle of the cavity. It's not in the interproximal cavity. Right? I prefer that the interproximal cavity is filled with resin and not with biodentine. Here, we wait until the setting, and we do the restoration. And this is the final, sorry, it says initial, but it's the final X-ray. As you can see, biodentine and the resin. This is the 3 years recall. And this is another case, 14 years old, and he came because he has pain in 36, and also he has a lesion in 37. And look, we see the abandoned sound dentin. So we go for selective removal in both teeth with biodentine. This is the final X-ray, 2 years and 1 month. I also see in my records this radiolucent layer, and for that reason I prefer that it's resin that is in the interproximal site of the tooth. This is 5 years and 2 months later. And the last case is Joan. He's a 13-year-old boy that came because his dentist could not remove the caries and says, okay, probably it's for an endo treatment. So he referred to the endodontist. I'm a little afraid that referrals will not refer me more patients because you see that I don't do endo. I try to save all the pulp, but I think that the main goal of the endodontist is try to save the pulp. This is a provisional restoration that his dentist plays. Look at the removal of the caries lesion and the placing of biodentine. You will see it here. This is the old biodentine. And this is the cavity fill. This is the final X-ray. 4 months, the patient totally asymptomatic, and 1 year. Let's start with the key recommendations by the ESE. The first is to absolute isolate with dental dam. They state, that our teeth should have asymptomatic or reversible pulpitis. As I told, sometimes it's difficult to know if there is a reversible pulpitis or not. We can choose between partial pulpotomy or total pulpotomy, and we should do follow of our patients in 6 months, 1 year, and yearly after that. And look, when we are dealing with pulpotomy or pulp capping, but because of caries, we should have magnification loops or dental microscope. It's mandatory for treating the pulp when there is a caries. Disinfectant, sodium hypochlorite or chlorhexidine, and a calcium silicate cement. Calcium hydroxide is no longer the gold standard. Now the gold standard are the calcium silicate cements. Radiographic diagnosis, I will not be here a long time because I said earlier, only for cavity disinfection. In that case, the patient cannot stand the sound of the handpiece, so for that reason I'm using an excavator. And you can see that first we start in the periphery, removing all the soft dentin because we want firm dentin in the floor and, as I told before, hard dentin in the surroundings. This is the placing. Once we have the pulp exposure, we use the disinfectant, we rinse with saline, we will see it in a case now, and we place the biodentine. And here is the first case. It's a boy, 7 years old, that had a trauma 6 days earlier. And he didn't came to any dentist, so 6 days he was referred for doing the root canal, as I have to tell you. But look at the nice pulp tissue there. So with an open apex, no root canal at all, because this pulp is vital, as you can see. Cleaning of the pulp tissue, you see here in the different pictures, we found sound pulp. It's nice to do a box at least of 2 millimeters, because the parents had the tooth fragment, so if we want to reattach the tooth fragment, it's easier if you have this 2 millimeters box and you place there the biodentine, not just at the level, so you can reattach easily the tooth fragment. Because time, when you are treating with children, is very important, so you have to make your life easier. And we place the disinfectant for 1 minute, after that with saline, and we place a sterile cotton pellet to wait until the blood clot forms. And this is a very important step. And it's a very long step also. No? It may take 10, 12, sometimes 15 minutes. No? And you have to wait, because if you place your biodentine too early, it will happen the same as with orthophosphoric acid. No? All the biodentine will stain with blood. It will not set properly, and also you will have static problems because it's an anterior teeth. So you have to wait 12 to 5 minutes for the blood clot and 12 to 5 minutes more for the biodentine to set. And look, we place it just level, we wait until it sets, and after that, we reattach the corneal fragment. Here you see the final pictures. And this is the initial X-ray, the final X-ray with the pulpotomy done. 3 months recall, where you can see the formation of the dentinal bridge, and 6 months where you can see the dentinal bridge and the continued root growth. And this is a case of pulpotomy. He's Ramon. Ramon has MIH and the molars, and look at 1.6, 3.6, and 4.6. I will focus only on 1.6 because he has a lot of pain in 1.6. In the periapical X-ray, we were not sure, I was not sure, to do a non-selective or a pulpotomy, no? A selective removal, sorry, or a pulpotomy. But once I start cleaning, all was soft tissue, and the pulp exposure was irreversible. I cannot avoid it. Here you see the pulp exposure. So we place the disinfectant, saline, and we wait until the blood clot forms, and we place biodentine and did the restoration. This is 9 months. This is 2 years and 5 months, and look at the nice formation of the mesiobuccal root. This is the last recall, 3 years and 4 months later. You can see the obliteration of the root canals. And this is my last case. It's a very special case. It's an autism. It's a boy that has autism, or some form of autism. So in that case, he didn't speak at all. So it's very difficult to look for clinical diagnosis, no? Because you cannot ask anything. The parents say he's in a lot of pain, but I cannot interfere that because I cannot speak to the patient. It was very difficult to treat. I have no pictures of the treatment. I'm sorry. I'm sorry also for the last final X-ray. It was very difficult. He cannot stand in the chair for so long. And he came 1 year and 3 months later. It was a pulpotomy, probably an irreversible pulpitis, but it's working, and it's working very nice. I say it's much easier than do a root canal here in children.